It's a beautiful sunny morning again in Nairobi. Day 2 of sun in the morning, something that we are not used to in the recent past. Welcome to New Day TV. I am your host, Chepkoech Towett, and today on the tackle we have State of the Nation. We are joined by two gentlemen. On my immediate right is Anthony Ngeru, he's been here before. He's the manager for media research in UDA party. And we have George Maroah, who is the Secretary General for Kenya Union of Clinical Officers. I have not hosted you, but I know you've been on the show before. So karibuni sana. Kindly go to our socials, that is YouTube and Facebook, New Day TV. Let us like, share, subscribe, comment. Today we're talking about this healthcare issue that has been going on. Day 47 of the doctor strike, day 30 of the clinical officers strike. So, SecGen, tutaanza na wewe.
Asante.
What are the issues? Karibuni kwanza. And thank you for raising. At least you've not come when it has been raining and flooding. Karibuni.
Thank you for making me meet my friend here.
Yes.
As he is the head of research, UDA.
Yes.
I'm also a member of UDA.
Karibu.
So he must know that I'm his member. So we are doing day 30 of our strike. It began on 1st April after issuing a 7-day strike notice that we issued on 25th of March. And that is how procedural things are supposed to be done when you feel you have issues that have not been fully addressed. And but let me start it this way, that you issue a demand letter to the employer, notifying that there are issues that you need to address. If they fail, then you issue a strike notice, because then you have registered grievances. Now, all those were ignored by the government, then we had to go on strike. We are now doing day 30. And there are many issues that we have. We have 10 issues.
Kindly highlight
the immediate.
Issues. Yes, the immediate.
We have classified the immediate, short-term, and long-term. And the immediate things that we want is the longly negotiated CBA, which we started in 2017, and the government has not been willing to conclude it. So we are saying this is at least our immediate issue that the government need to finalize on. It has also some aspect into it. In 2021, we negotiated and agreed on enhancing a risk allowance for clinical officer from 3,000, because they are paid. They are the lowly paid. So it's to be enhanced from 3 to 15. That's an increment of 12,000. I must put it very clear that when we talk about that, people think that's big figures. Like the ministry require only 10 million to implement by virtue of the number of clinicians it has. Majority of the county need 20 to 25 million to implement this.
In fact, I was going to ask you why the figure 15,000. How did you arrive at that? So
we were looking for 30. Then the CS then Mutahi Kagwe, the one who was on the table, came midway and said, no, we can actually start from where we are. The highest paid in risk allowance in the sector is 20,000. So for us, because the clinical officers where we serve, we feel that then this is an allowance that actually we ought to be earning higher, because we serve as the gatekeepers in those facilities. We are the first people to see any patient who come in those facilities in an enclosed area. And you see a patient without any information of what kind of condition they are suffering. And that's why you'll find if it is infectious condition, then our members suffer more. Including COVID time, we had among the highest infection for clinical officers. So we said then we should be earning higher than anyone else. If then any proper criteria should be used to award such allowance in the health sector, then the clinical officer should earn more. But when the CS intervened, then we said, okay, we can begin there. And that is how it was agreed and signed in 2021. But up to date, it has not been improved. So our push is implement a negotiated enhanced risk allowance. We have another issue of career progression that we used to use the scheme of service. Now the scheme of service was put to a halt, or rather is being replaced by this career guidelines, which since 2017 we have reviewed every year, since 2017, but it has not been approved up to date. Reason not known, which means if you see the letter in 2019 that was done by the peers in the Ministry of Public Service, annulled all the scheme of service, saying we have replaced them with the career progression. But there is no career progression in place up to date, which means even promotion have become a problem in the sector. Counties have no document to make reference to. But for those who have dared even to do those promotion, they are using the older document, which is already annulled by the CS. But because there is no you can't allow a vacuum to continue being there, so they go back to the older document, which in any case it is outdated and it does not inform properly in terms of the professional growth wise. And now we are saying that's also an immediate thing that should be done, because that document is there. It's only going through and ascending to it, or rather approving it for purpose of using. The career progression informs the entry point for any professional. It informs the exit point. Where do you start and where do you end? So that it can now create your way, how you grow as a profession. It always also informs the employer in terms of how do you promote. So that is what we are missing. And we like when we complain, counties are not promoting, and most of them say that we don't have any document that is informing the policy. So the other issue, which is also key, we are talking about the UHC staff. Let me use the word contract, because last year we had a conference which was headed by the head of public service again, and we discussed the HRH, human resource perspective in the sector. And we said that we have had close to over 100 strikes since we went on strike. We went to county. What is the attributing factor? Most of them are touching on the human resource. A delayed payment at the county, non-payment or withholding salary for workers, dubious contracts, and they'll get some of them is failure to promote and designate workers. So all those issues have contributed to all those strikes that I'm talking about. But also key to note on those issues is that in 2019, when COVID came, we realized that our system was so weak. We didn't have enough staff. So we rushed and employed close to 10,000 workers together. But we realized then, because we are being funded by the World Bank, we didn't have enough fund. We gave them a name, UHC staff, so that we underpay them, we undervalue them. Because then if you give them the title clinical officer, you ought to equate them to their equivalent. But you see, you negate that and give them a name so that you pay them lowly. So they served for their first term 3 years, which ended last year, and we were negotiating that they put them on. At least reward them for having actually served this country during such a hard time to PNP, so they are put on permanent pensionable. There was resistance then, but we took this matter to the Senate, and Senate resolved that indeed they need to be. And the Public Service Commission, which advertised for their position, also extended their term for 1 year. But the Council of Governors, who they are serving under, gave them papers, contractual for 3 years. So the first year, the year that was extended by the Public Service Commission is ending this May. The paper that was given by the county is still extended for 3 years. So you have the ministry which is holding, the Minister of Health and the Public Service Commission says, give them the PNP. The county government is still holding, let them go for 3 years. So it is same government, different position, making people to suffer Already these people who are under UHC, who are actually managers in most of the facility, because 10,000 in our sector is a huge number. So you realize that they are already in agony, they have a lot of anxiety. These people are not stable mentally to continue serving even, because you have subjected them to a future that they don't know what is to happen. So we are still pushing that government must put them on, because the ministry has indicated they have a budget for that. The reason why the Council of Governors is not willing to do that is known by themselves. Whether it's about priority, we do not know. But we understand that since we went to devolution, the counties have come up with a plan to employ people on contract. Put them on a short-term contract, they fire them when they want, and bring other people who are compliant in terms of their political realignment. So this is affecting service delivery. Actually, since we went to devolution, the issues of service delivery have been more of politicized. That today, if a governor comes in, he fires the one that had hired as a governor. Then when I'm out, then the other one come and fire. It's quite unfortunate, and we feel that if those issues are not addressed, we will more of kill the public sector, and this is akin to say that then we are actually privatizing the health sector in the country.
Okay, and thank you so much, SecGen, for taking us through the issues, because context is important. When we see the clinical officers and the doctors on the streets, some of the issues that they are raising are actually pertinent issues. And Gero, this is where I want you to come in. It is good that George has touched on the counties. Was it a mistake to devolve primary health care to the counties?
If you only allowed, I give him 2 points so that he start from there. The other issue is about employment of more staff. The Auditor General report on the facility 2021-2022 has indicated a glaring gaps in terms of the number of staff that we are supposed to have. Can tell you, like Msambweni Referral Facility, which is supposed to have 323 staff, it only have 117. There is also Kiambu Referral Facility, only have 200, it has 157. So a majority of the level 4, all of level 4 facility do not meet, not even halfway of the staffing norms. So which means this contribute to the reason why those Kenyan come there, they take the whole day waiting to be seen, and they are not even seen. And they can see halfway. When they are sent to the laboratory, it is too late. They run home. They come back again tomorrow. So they waste a lot of time to waiting to be seen or to get services. So when we talk about employ, is not really our agenda. This is a government agenda. In any case, the blueprint, or rather the manifesto for Kenya Kwanza, was to employ over 20,000 healthcare workers immediately. So this is not our agenda, but we are only telling government that you must be accountable on what you're supposed to be doing or what you promised Kenyan. The last thing is about interns. Interns training is key, because then the healthcare workers deal with human body. They deal with life. They are the voice and the liveliness of every individual. So if you have a person who is not stable, serving in the health sector, in any case, they are putting every patient who pass through them in danger. And that is why they must be fully well-trained and meet the international standard, because in any case, the labor is not about for Kenya. We can actually train these people to work outside the country. So the international standard is for all clinical workers, who are working in the clinical area. That's to mean a person who make determination about what intervention to be done on a patient. The clinician, the medical officers, and to some extent the degree nurses, they are supposed to have a very high training. As to mean, once you have done with your theory in school, we take you and put you under qualified staff for 1 year to acquaint yourself with now how to make decision using the theory that you learned in school. That's what they go through. But in any case, they are actually working, because they do 3 months every department, and it is within the 2 weeks you are under supervision, then you are led to do. You only now do consultation where necessary, but they are working. If you go to any of this government facility, public sector, they are the one who are in a patient, they are the one who serves people. So Public Service Commission, which is the only constitutional body that's mandated to establish position that people can be paid for, that any employer can use to pay, has already established their position. And if you look at their document, they have approved 9,500 staff. That is the medical officers, the pharmacists, the dentists, the clinical officers, both degree and diploma, and the nurses degree. So those are five category of the people who constitute the 9,500. So this year, the people that we are talking about is only 3,557 that are supposed to be posted for internship that have brought all this issue. But you wonder that the government has been paying as per job group for over 7 years, but they have realized today that we cannot afford. We feel that is being dishonesty, and the government need to honor and do their responsibility. Thank you.
Anthony,
yes.
SG has laid out the issues for us, and I had asked, so one, before we even go back to the issues, do you think it was a mistake to devolve primary health care to the counties?
Thank you so much, Chep, for that question, and thank you for having me here again this morning. It's a beautiful Saturday morning. Thank you, Katibu, for also honoring the invite. And I think the issue of devolving health is something that has cropped up before, and I think for now we have moved away from that discussion, because the idea behind devolution was to ensure that all resources and all services reach the local mwananchi in a way that is sustainable, and in a way that they will be able to receive everything that they require. And if you look at the health sector, I'd say that we have 60%, 40% shared from the national and county. Normally, we usually say 90-10%, but taking into consideration the referrals in the health sector, and also some other aspects of financing. But I'd say that first of all, the current conundrum that we have in the health sector is something that is almost coming to a close, because we were able to sit down with the doctors, and we were able to agree on the 18 issues that they had put forward. I think the major issue that remains is the issue of internships. Interns, I mean. And we were just having a side chat with Daktari. He has also touched on the issue of employment, and he was very clear that he was part of the team that sat down with our campaign strategists to come up with our manifesto. And you know very well that we have a plan of employing more health staff in all cadres. So, and if you look at our manifesto, it has been broken down into 3 phases. We have the long-term gains, the short-term gains, and the quick wins. And by virtue of Katibu being here today, he is representing the interests of clinicians, if I'm not wrong, right?
Very true.
Yes.
Before we go too far, allow me, why I asked if devolving primary health care was a mistake is because Katibu has laid out for us how there is, first of all, a communication challenge between the national government and the county government, because the UHC staff, as you have highlighted for us, had been absorbed for 3 years. The contract lapsed. They were given 1 year, which is lapsing in May. But the county government extended for 3 years, right? And there is no that communication between national and county government. That is on one part. On the other part, Katibu has clearly explained to us that when it comes to the promotions, You know, the counties are saying they want to promote, but they have no documentation or policy or framework that has been done for them to fall back on. So what are they doing? They are using something that is null and void that was even done away by the ministry a while ago. So that is why I ask, because devolution, as much as we want to sit and celebrate devolution, we also have to be honest in asking the hard questions. Is it working? You know, it is not just saying that devolution is closer to the people and all these things. It is closer to the people, yes, but is it working for the people? Daktari has, Katibu has also clearly stated for us that most of these level 4 referral hospitals are understaffed. When you talk about understaffing, it means that person at the county level who is supposed to directly benefit from that, which has been clearly stated that sometimes might even take 2-3 days in a process in hospital. The resources spent on that, is it fair for the people down at the county? So we are asking the hard question, is it working as intended, for the counties to work for the people? We have seen the governors also, like again clearly stated in the health sector and many other sectors within the county, that when they come in, they might decide that, Chep, you did not campaign for me, so you and your people get out. I am employing my own people. So where is even the continuity of government? Because that should be there. Because when you have continuity, it shows that when this system, there will be no system breakdown. So is the devolution working as intended for the people? And as intended by our constitution? Because at the end of the day, devolution is to do what? Bring the resources closer to the people. So are the resources closer to the people? That is one. And resource in this instance even means human resource. It's not just the money. So, Katibu.
Yeah, let me respond to your question about the issues of health, devolution, that's the county and the national government. This is one of the difficult things that I normally feel that, or rather the easiest thing that have been complicated by a politician. If you look at Article 43 of the Constitution, under the human rights, it has given that responsibility to the state, that the state has the responsibility to ensure that every Kenyan has access to highest attainable standard of health, including maternity issues and child health. So when you look at that being negated, you wonder whether, is that a county issue? Is it a state issue? Look at the schedules that now devolve the function. It says primary healthcare. What is primary healthcare? Where does it start and where does it end? Now, national government retained the referral services and the policy making. Now, when you look at that, then you hear when the president indeed came in, he wanted to move because they actually in the also Kenya Kwanza manifesto they promised to establish a central body to manage the human resource, because we had a fully informed president then when he was a candidate that the issue which is a glaring problem which ought actually to be addressed is the human resource. Leave alone crawling back, or rather taking back the whole health sector, because health has 6 pillars. That is the human resource, the infrastructure, service delivery, we have health, we have leadership and governance, and we have now health financing. The whole issue of health financing is the national government. Now, when you talk about the human resource, the training for human resources we reserved with the national government. The employment now at the county level, but also shared with the national government, because still the national government has a responsibility to capacity build. And that's why they were able to employ and post staff through the UHC under the county. So when it is convenient, it happens. When it's not convenient, there is a lot of fight. So, and I normally feel like when the counties always continue holding that health is devolved, we as the professional hold that health is a shared function. Now, what is shared? Because when you talk about referral, where does referral start? We have now established people called the community health promoters. Community health promoters are the link between professionals and the community or the household. Because then, again, the same document, which is now an act of parliament, establish household as the the first level of service delivery. Meaning, you have a we as the government have given us a responsibility, or the government has given itself a responsibility to ensure that at your household you get services. So these people who have been put there, they start referral. When they get you, a child who has not gone to school, sleeping at home, and is sick, the first thing they do is to get this child and process this child to go to the facility. That's called referral. Referral is not just a facility. Referral is a service. So that I'm able to connect you to the next person who will give you the services that you need. That's what now we totally miss. So when you see even government, county government complaining of national government paying the community health promoters, that they are the one who is supposed to do it, what changes? People are looking for services. We don't care who pay. And that is why we say if we establish a central body away from this whole shenanigan of who owns the health sector, then that you are able to promote. We have counties that have never promoted. Kirinyaga is one. Since we went to devolution, over 10 years, people have never been promoted. It is also a county that has never employed anyone on permanent pension and pensionable term. They put people on contract, fire them when they want, give them a lot of intimidation. Actually, people, when you speak to people in Kirinyaga, they feel like, the workers in Kirinyaga feel like they are not in Kenya. Because of the still fear, and the county government have managed, because they have put people on contract, they have removed people from even the union. So the voice of the union has been blocked in Kirinyaga. So that's the kind of things that we are talking about. Like, we need to have workers who feel supported, workers who feel their welfare, or rather listened to, that their welfare are addressed. And when we complain about missed diagnosis or wrong diagnosis, is about the quality of time a patient is given by that care workers. That is the clinician, because the WHO document that for me to let a patient in, listen to their issue, touch them, meaning I do examination, and then send them for laboratory test or any other test that is required, and then they come back for me to interpret and now put it into medication, it need to take at least 15 minutes. So if I was to see a patient with such a quality time, I can only see not more than 40 patients in a day. You have clinicians seeing more than 100 patients. This is what is attributing, because then again, you must see them. You must clear them. They are there. There's no one else to see them. It is a circumstantial, it is actually a deliberate that the government is not prioritizing the issues of health, because in any case, a majority of these leaders in the government seek services in the private sector, where they walk in because of their money, they are seen within a short time, they walk out. They do not know the experience that Kenyan go through in this public sector, in the absence of clinician. Government have done, again, their research last year. It showed a majority of the pregnant mothers, expectant mothers, they lose life at night and weekend. Meaning, it is because of the absence of workers by that time.
Okay, and Mr. Ngeru.
Yes.
We have touched on the issues of government, and even I like the fact that SG has touched on the issue of intimidation, because when we talk about work environment and positive work environment, given that now we have the awareness of also mental health awareness, this is someone that is supposed to see other people to help them out of whatever issue it is that they have, yet themselves they have been pressed with so many issues that they are dealing with, and you know, and the intimidation and all this. So how do you expect this same person to serve other Kenyans and to ensure that they are safe. Because remember, we are not just talking about a servitude that is, it is literally a matter of life and death. So if this person is not in the right mental state, if this person is not in the right work environment, we are also risking lives of Kenyans that are already at a disadvantage.
Yes, thank you so much for that question, and thank you for the issues that you've raised, Daktari. Of course, you've touched on one of the issues that I really hold dearly to my heart, and that is the issue of community health promoters. And of course, we've had that challenge of mothers home deliveries, and ideally we are supposed to ensure that every delivery is done by a skilled health worker. And that is why the government is so intentional about strengthening primary health care from a household level with the sustainable referral system to the health facilities. And yes, of course, as the government is listening to all the issues that the doctors are raising. And like I've stated, if we were able to come to an agreement on 18 issues that they brought forward, why are we not just able to surpass this one issue of financing? And like I said, we had a said chat with Daktari here, and some of the issues that are pertaining the remuneration of the interns pertain some allowances that they are not supposed to be receiving at their current state, because we all agree that it is a global practice for interns to go through internship because they are fully certified as doctors, but there are some functions that remain still with the main doctors, and there are some functions that they cannot completely do without any kind of supervision. And some of the issues that Daktari has raised about health financing, I think for us, the issues that we need to look at is efficiency, because structures have been put in place. Of course, there's that synergy between the national government and the county government. Like we have said, there are shared responsibilities from each sector, and I feel like all sides should be very intentional about ensuring that service delivery has reached the common mwananchi to its full optimum. And that's why I really feel like we really need to deviate from the issue of returning health to the national government.
But you see, Anthony, the other issue that we have here is if it is not working in the county, because you've said there's the symbiosis between the national and the county government. But some of the issues that Katibu has raised over here goes to show clearly that there is minimal or no communication with how things are being done between the national government and the county governments, especially in regards to employment and promotion. That has clearly been stated. But also, in the same breath, when you say government has been able to agree on 18 issues with the doctors, and that one issue that they cannot agree on is the reason why we still have doctors not in hospitals. At the center of all this, I want us to remember, is Kenyans, innocent Kenyans who have nothing to do with what is going on. And some of the rhetorics we've seen online, whether posted by doctors or not, is they have said even take back the 18 issues and let us deal with this one issue. What I am also going to ask about is the growing wage bill. Because when we tell the doctors we cannot afford 206,000 per intern that you want, but on the same breath, SRC is reviewing upwards the salary of the executive, it doesn't make sense. And even the doctors themselves are asking, how can we negotiate for 47 days and 30 days with the clinicians? You tell us that we cannot agree on this one issue because of wage bill, the wage bill is growing, the government cannot afford. But on the same breath, SRC is reviewing upwards salary of the executive. And that is where Kenyans want honesty and transparency from government. When you tell us that the wage bill is too high, when you tell us austerity measures and all this, we should see it across board.
Yes, I do agree with that, and I think if you look at the current remuneration, how the government remunerates its employees over time, the Katibu here has spoken about promotions, and over time, personnel who are employed by PSC receive promotions, and that is not something which is very unique from our remuneration, the way the government remunerates its personnel. And one of the issues that has been very pertinent, of course, it's the wage bill, and over time it has been reducing, because if you look at the amount of money that we used to pay our employees in reference to some of the revenue that we collected in 2021, we were at 54%, and currently we are at 47%. And what the government is trying to say is that 47% is still not sustainable, because the recommended percentages should be at 35%, because we also have to pull resources to other development areas that are pertinent to our wananchi. And if you look at some of the austerity measures that the government has put in place, of course, there's the current IDA, heads of state meeting that is currently ongoing in Kenya. And if you see some of the things that are required of us so that we can, receive some of these grants from outside, we have to look at our budget in a very deep way, and we have to look at areas that we need to reduce our budgets. Of course, the president was very categorical. He recently shared some of the practices that the government is trying to put in place to ensure that there is minimal minimal wastage. And of course, another issue would be putting a hold on unnecessary hirings. And another juncture is of course increasing our revenue. And if you look at the tax to GDP ratio currently, we are below what we are supposed to be at, because I think in Kenya we are currently at 14%. And if you look at the medium term for plans, we are supposed to increase that by 16%. And some of the discussions that are taking place in the current IDA engagement with African heads of states, they're looking at a way that they can increase the pool funding from 12 trillion to 16 trillion, so that we avail more resources to development.
Is availing of more resources, and I'm coming to you, Katibu, with this question, is availing of more resources the issue? Because even the resources that we have seen a lot of pilferage. We have seen a lot of corruption, whether it is in the counties or the national government. And some of the measures for us to be able to manage even what we have before we go to ask for more. What are we doing to manage what we have?
So when the president was campaigning, you heard him saying that every day around 10 people are prone to actually to go poor by virtue of just one of their members getting sick. Only one. And then that is why you saw the Kenya Kwanza manifestos heavily spoke about having a policy shift from curative to preventive services. But again, that is the reason why every Kenyan today, if they get sick, they are willing to sell everything they have to protect themselves. Why? They know that the issues of health is ni wewe peke yako. None is there for you. Remember when we talk about insurance, only 24% of Kenyan have one or the other type of insurance, either private or. So a majority do not have any. So they actually go out of pocket or do harambes to contribute. Now, when we talk about resources, what is it that we are talking about? In the year 2019, 2020, when we had COVID, we spent 550 billion. Out of that, only 159 was government money. All the other money were partners. So we have key, crucial programs, HIV, TB, malaria program, all of them are funded by our partners. If these partners today, they say that we are not willing to continue, the government will crumble, I can assure you, because they have never thought. And you remember, that is why the government, you have read the Kenya Kwanza Manifesto also, they had a projection to ensure that they can plant a seed where if there is a gap in terms of supply of the partners, like when you have heard us cry that the HIV people have missed their drug, it's because there was some confusion in between the partners who give us this medication and not. The government is a signatory to the Abuja Declaration, where we normally commit that we will put 15% of our national budget to health. Remember, a healthy nation is a wealthy nation. If you are sick today, the time you waste on a bed, or rather in the hospital, is not productive. That's to mean you waste your productive time being either in the hospital or at home waiting to be treated. So when you put all these factors together, like focusing on preventive, is you reduce the time for medication. You reduce the time that you seek to go to the hospital and you become productive. Again, you reduce the cost of medication and the focus on preventive, so that then we normally say every shilling used in preventive is actually saves 9 shillings that we'll have used in curative. Mm-hmm. So that is an effective method that have been used elsewhere. So government have deliberately continued to actually, with their rhetoric without action, which we expect that we must put action, so that then we reduce all this complaint about what's not happening and what is not happening. This wage bill thing, when you talk about wage bill thing, I have been working in the government. I entered as a diploma holder. I'm still earning less than 100,000. When I was employed, I was earning around 38,000. So today I still earn less than that, despite the service that you do in the government. A majority of the clinical officers I represent, they don't earn even above 100,000, despite the difficult time that we have. Their house allowance is between 4,000 to 6,000, which means they have been confined to stay in Kibera and the Madare. They still do not have a comprehensive medical cover, which is one of the issues we are raising on our strike notice. Which means the services they are offering to Kenya, they can't afford them. It is a bigger problem. Now, when we talk about all these issues, what we are saying is that the SRC have become the union for the employer. So the people who are sitting in the table making policies, who represent government, actually they are the face of the government, because they have a call directly to the SRC, they continue getting a hefty pay, because the SRC herself, she earned more than $1 million. Her PA earned more than 600,000. More than a clinician who is offering services, more than that PA who is walking around carrying bags. We, as a country, we know very well the responsibility of the SRC. It's supposed to harmonize terms of employment, and ensure that this pay, whichever you are paid, is translating to the output, to the work you are doing. Now, the first time when SRC started the work, they used a tool called Patterson Patterson management tool, HR management tool, which they borrowed from South Africa. And they came applied it across. That tool in the South Africa, it applies to a sector, more specifically the commercial sector, where your output is more about the money. Our output is about life. And our advocacy is that employing staff, paying health staff, should actually be shifted from a recurrent expenditure to development expenditure, because in any case, ours is not at where you can weigh in terms of how much do we generate in the hospital. It's about the status of health for the people in the country. That is our output. Now, when you go and cluster it together with the other recurrent expenditure, where we know, of course, again, using wrong figures, because when you hear Moses Kuria talking, or rather even the president, that around 1 million people taking over 40% of the total collection of our country, let's segregate. Can we put it like, how much does the parliamentarian takes? How much does this executive take? How much that goes to every sector? We know that our budget runs to trillions, close to 3 trillions. This is not a small figure. Now, the health sector, which we call is a key sector, that is actually a complement of any economical growth of any country, you have seen it neglected with the kind of allocation that it gets. How much did we have the current running budget? Mm-hmm. A negligible amount of 132 billion.
And in the Abuja declaration, you
Yes.
should be getting 15%
Yes.
of the total budget.
So we are only saying that we run the health sector by virtue of the well-wishers, the partners. Can't we change and get to say, let's do the right thing? Now, when we talk about these wage bill things, the SRC need to break it down, because I saw them when they have been highlighting the issues of the doctors. They will have break it down, because we have close to over 17 cadres in the health sector. Break it down, everyone, what you pay. Break down even you yourself what you earn, so that Kenyan can see and judge and say, what is it that you're telling us? Are you trying to maybe malign the doctors? I mean, also, is it that you're only prioritizing the issues of a certain group of workers? And then this whole issue continue affecting the workers. Why am I calling the SRC a union for the government? They have come up with a policy to say the CBA for workers can run 4 years. What is a CBA? A CBA is supposed to be renewed as the changes come, economic or issues that informs how the country is growing. Then that is why also government renew their policy statement every time they find that we need to flex. That's how CBAs are supposed to be. So then workers feel accommodated. When Uhuru realized that all the workers in the country have been released to stay at home and work from home, what did he do? He relieved the workers who were going to work, that's the healthcare workers, relieved them of taxation. You remember that? And this was to support them, because then he realized if we don't do this, these people also, they are feeling they are the only one who are doing 1, 2, 3. The SRC, who is the advisor, ought to be proactive. They should not be the bottleneck of negotiating CBA, putting it 4 years, and yet the government, the country economy changes every year. The determinant of the growth of economy continue changing. So for instance, currently, as you see the flood rampaging, killing many Kenyan, we ought to expect that there will be other measures that, of course, utafunga a certain project, because the money must be redirected to save Kenyan. These people who are losing life because we are on strike, they will never wake up to come and celebrate any good gain that will come tomorrow. Our prayer, or the wish of the president to realize UHC, which he launched for the 4th time after Uhuru launched it close to 3 times, will remain a large if he doesn't focus on the healthcare workers, who are the engine for the healthcare delivery.
And to our viewers this morning, I would like you to go to our social media pages. That is New Day TV on YouTube and Facebook. Like, share, subscribe, comment. Let us have a conversation on these issues because they are very dear and very close to our hearts. And as Katibu has told us, a healthy nation, a wealthy nation. If we do not find a way forward in this conundrum, I don't know what we are going to do as Kenyans. Kwa sababu fahali wawili wakipigana, nyasi ndio wanaumia. Unfortunately, in this case, it is innocent Kenyans going through it. Katibu, you mentioned NHIF and insurance, that even the medics cannot afford that kind of insurance, or they cannot afford the services that they give. We saw the transition from NHIF to SHIF, that is Social Health Insurance Fund. But also the transition period is that SHIF begins to operate or operationalized in July, 1st of July. In between, I want you to remember that we still have pregnant women who need to go and give birth. So the maternal health care is an issue there. Some hospitals, most hospitals, are now not taking NHIF because for the last 1 year, nothing has been remitted to the hospitals. And then it is said that the SHIF will begin to work in July. So the transition period and how we plan our things as a country, says a lot about us. Because in this time, like we say, there are people who are still getting sick. There are mothers who need to give birth. There are children who are being born that have to be taken care of. There are the mirage of other issues that even Katibu has raised. How are we supposed to handle this as Kenyans? Because, sometimes when you look at these things, vis-a-vis what you are taxed for some of these services, it is even painful as a Kenyan to pay that tax. Because you start to wonder, okay, I am paying for what exactly? I cannot get the National Insurance Fund, which is supposed to cater for me because I have been deducted. And also, as all this is going on, deductions are also going on. So how do you come back to Kenyans to tell them that, guys, we are sorry, lakini lazima mkaze mshipi?
Thank you for that. And the idea of social health insurance fund is a brilliant one, if I would say, because I think one of the issues that the clinicians and the doctors are trying to raise is the issue of health insurance. And I know, and I'm very positive that, Dr. you have a sustainable health insurance, right? So you really don't have to answer that. But the idea behind social health insurance fund is to ensure that there's some sort of resource mobilization in a way that, and ideally that's why we are dealing with percentages, so that the person who earns a lot is able to cover for this person who earns less.
Anthony,
yes,
my issue is not even in the deductions or the percentages. My issue is in the transition, and the question is in the transition.
Yes,
because if NHIF has ceased to work, and you have seen hospitals turn people away for lack of government remitting that money. You understand? So what is the Kenyan who is being deducted supposed to do?
I think the issue of transition is one that is being handled behind the scenes very well, and it doesn't have to be politicized because it's something that is very crucial and it is very dear to every Kenyan.
I think Anthony is behaving like a child. Where I come
No.
When you are a child, you can't tell your mother sit properly. So Anthony is behaving like a child to a mother who cannot tell.
Daktari,
you know what I'm saying?
Let
me put it. At least respond to a few things so that they also catch it up. That for a fact, social health insurance is a brilliant idea. But once the process begin in a wrong way, it casts aspersion. Trust normally disappear. In health, trust is the biggest investment that you can ever have. That is why a patient will be very comfortable with a medic that they know has addressed them, Whether you have what qualification, that's the person. Even if they go to a certain consultant, they will call back and say, I've been given, will I take? So already Kenyan had utilized the Linda Mama program, which I have my own reservation. We had the Edu Afia, I have my own reservation, of which we knew that all this multifaceted program was actually killing NHF. Because in any case, you will be moving around hospitals that have been accredited to see the children who are benefiting under Edu Afia. Every Thursday, watoto wanakuja there wanakuwa admitted more than 20. And for the purpose of just claiming money. So the officers, the NHF, they normally work together with those facility owners, and they swindle money from the NHF. So until you put these things together as a pack, because in any case, the insurance is about creating a pool. You don't then again break it down, it becomes so costly. And that is why this process ought to be thought through. Ikishafika hapa, when you transition, people should not experience difficulties. We have gone to places and the people are turned away because NHF, they are told, we can't use this. Because in any case, those facilities are filling, it will take longer. But again, I understand that the transition team realized that there was a lot of gap, there was a big gap, a lot of gap when you go there to try now. Because when you're transitioning, you must get right in terms of the money, I mean the whichever you are inheriting. So that you don't just come and then someone turn from there and say, you know, NHF owns me 3 billion. And yet, you don't know. So they went there to investigate, and they have realized, by the way, there have been a bigger problem with the NHF because you want to inherit someone who is claiming money, but they have not offered services. So until they get that information right, I still encourage them not to hurry. But however, it should not be the reason for Kenyan to lack services, because in any case, paying taxation is not a bigger problem to Kenyan. It is about our taxes translating to the services that we want. If it does not translate to that, I think I encourage every Kenyan to be up and arm and ensure that government must be responsible for the money they are collecting from us. I can't pay high taxation. I still pay high school fee for my children. I still pay out of pocket for my medical services. It doesn't resonate. So which services should I expect?
Daktari,
you move around in Nairobi.
You know very well.
The roads is not passable because of potholes that are there. Where is our money going?
Daktari, you know very well that the issue of NHIF was a systemic issue. The issue of remittances was a systemic issue, and it is being addressed. The amount of money that was not remitted to the hospitals. So I just want to put it clear out there to Kenyans that the government is very intentional about the implementation of UHC. People are working behind the scenes to ensure that the transition is very, very smooth, because if you look at the social health insurance fund, the social health insurance, it is such a good, especially for those who cannot afford. You can imagine for someone to access all health services for only a minimum amount of 300 shillings. That is for the border rider, and for the border riders and the mamambogas. And I just want us to look at this thing objectively, rather than just bash it because of every good idea. Every good idea has its own fair share of challenges, and we need brains like Katibus so that we can build upon this good idea that the government has come up with, so that it is effectively implemented.
Anthony, we are not bashing. Like Daktari has said, when I give my money, I Chepkoech Towett, my money is being deducted. I am paying for NHIF. I expect a service. It is not bashing. I expect a service.
Yes.
If I get sick today, God forbid, and I am taken out of this door, where do you think, for example, my colleagues will rush me to? Because even if they take me down the road here, Mbagathi or Kenyatta, is NHIF working? We are talking practicalities. If today I fail as I'm standing from this seat, they cannot take me to a public hospital. As much as I have NHIF, I have the card. I'm a paid up member. What is the immediate thing they will be told? We are sorry, we cannot accept. As a Kenyan who does not have any other option, Anthony, I am asking the question on behalf of all of us. What is that person supposed to do? And we are not bashing. We are asking a simple question. Because without any other insurance, apart from NHIF, who is the border rider that you have talked about? What I will automatically do is go back to my pocket. Money that I might not have. I will have to call for fundraising, like Katibu alluded. You understand? I will have to call relatives. These people will have to scatter to ensure that I am treated. And that is just, I am talking for the basic Kenyan. We are not bashing. We also have to have honest conversations, both as government and as citizens. And when something is not working, I should be able to ask that question because you deduct tax from me.
Yes. Equality, if you look at the gazettement of the SRC for the CAS, the benefit for their medical insurance, you'll be surprised how much money government is using on one individual. But we have thousands of older people who cannot work, cannot do anything. They do not have medical services. Where should we put our priority with this now insurance thing? And I need to say, he asked me whether I have a good, and I said, he doesn't know because I'm the one who knows where the shoes is pinching. The issue with the county is procuring a comprehensive cover with the hidden agenda. They go procure with the private entities, Madison, AR, among others, but they don't publish. We went to court in 2019, and the court declared that when you procure an insurance for the staff, it is a public issue, it's a public procurement. Using public resources, you ought to declare, put it to the members that I have secured your medical insurance from AR, which has this benefit. You put it in public. So every county that came to court, none of them demonstrated any public contract engagement with those insurances. So what does it mean? They go privately, they tell you there is, very few will benefit, but a majority of the money, that is because at the end of the day, they claim the 40% from this medical insurance. It's private business. Our position has been that the money that is being used to procure private medical insurances for the staff be put under NHF. Then we will surpass the 280 billion that the president is looking for the NHF to run properly. Actually, we will collect more than 300 billion in NHF. If you find Nairobi using 120 billion for the staff, procuring from AR, people who do not appreciate those services with a lot of limitation, because then a medical insurance is about the package. It's about my benefit. It's about me not having the knowledge of the benefit that you are procuring for me. So then I can be able to access it. So these hidden things that is happening, even from the police one that is taken from when to do to what, all these are blackmail, and it doesn't amount to medical cover that we want. We want a cover because I'm already paying at the NHF. Please complement what I'm paying for at the NHF. I don't want multiplicity of this, because in any case, you can't use two cards at the same time. You cannot. So at that time, what I'm saying is that let us be focused and be transparent in terms of what we are doing for people to benefit. So this issue of insurance, and as I've said, it's a brilliant idea to have this. But if you want to treat people equally, please remove this private thing where you see, because whichever is being declared for public officers and state officers, they get hefty of over 20-something million for their medical insurances. So that's why they fly outside the country every time they have any problem. They have been given a lot of money, government money, that will have actually been used to strengthen the system in the country to ensure that everyone can access that services that you go fly out to go and look for.
Katibu, it is not government money. It is public money.
Yeah, public money. Government is us. Yes. It is not the people who are in those positions.
It is us who are being deducted. It is public money.
You know, you've raised a very crucial issue about like a normal person when they are faced with health challenges. They have to go through harambees and stuff. And initially, when you look at such ailments as kidney failure, dialysis, and such kinds of things, cancer, chemotherapy, initially, these things were not covered. Or if at all they were covered, they were only covered up to a certain extent. And to bring that, not equality, but equity among everyone, it was paramount that such kinds of things were addressed, because Daktari, when you're talking from a perspective of maybe yourself or the people that you're representing. But us, we are looking at everyone, the normal mwananchi.
What about the scenario that I gave you?
Because they know how they suffer.
Yes,
what about the scenario,
very well
Anthony, that I asked you of me, Chepkoech? Mimi hata sio katibu, mimi sio anything. I am just a normal Kenyan.
Yes.
Who today, right now, as we are ending this show, I stand up and I collapse. And my colleagues have to do something about it. I have NHIF, which is being deducted.
NHIF is working. It's supposed to be working, and it's supposed to be seamless to every mwananchi. And ideally, if there's a scenario like that happens, you're supposed to be taken to the nearest local facility for emergency, and you're supposed to use your NHIF card, and it's supposed to cover your treatment. And I, from where I sit, I know that it is working, and it should be working.
I like because you've used the word suppose. Because we've seen a lot of Kenyans, even the ones that I know personally, who have been turned away. You know, when we talk about these issues, Anthony,
that is very illegal.
It's not political. It is just the reality on the ground. We have seen hospitals, even on newspapers, being published to say, we cannot take in patients of NHIF because the money is not being remitted. That is a fact, Anthony.
I want to give
it is a fact. And yes. You're on the ground.
Fact, I took my child for dental review at Gertrude, and I was told that NHIF is not working. So I had to pay from my pocket. That was last week. Yesterday, a friend of mine called Alex works with KTN. He took his mother somewhere. He is on chemo. And the amount that they required, because Akona NHF fully paid, is 49,000. They have approved 18,000. So where is all this money going to come from? That I have been paying diligently. I am up to date. I don't have an arrears. You only go apportion 18,000 out of all the money required at that time for chemo to, because then you have to do you check the arrangement, the kidney function, you do the liver function test, you do the full hemogram. There are a number of tests that you have to do by that time you take the patient there. And then now you take the chemo and also do the post check. You only allow 18,000, subjecting this person again. This person feels humiliated because in any case should have prepared that there is no money I'm going to get, so that then they prepare to go even sell their cow to come and support the mother in school. So these are the things. When we talk about social health insurance, is treat everyone equally. And then ensure that, indeed, you are able to cover where necessary. And I like it the way it has been braked, because we have three cover in the social health insurance. The one for emergency and critical illnesses, the one for social now, and the one for it's called, I'm forgetting the third one. But you see, the social will be covering the lower facility below 4 and below. And that's where the government is supposed to put money fully. So before you pass there, you can't go to the upper facility, so that you get a whole process. And we are trying to kill where a patient walk from Kibera, go to the referral facility to seek treatment for flu. Because if you go there, even the medication you will have gotten in a lower facility at around 50 shilling, it will be sold at 500 shillings. So the costs go higher. So we reduce that by ensuring that first, utilize the lower facility before you are processed to. But again, the emergency is to cover the Alex Madaga issues, where you are boxed in between the facility until you die in between, raising the deposit for you to be admitted for services. So the government takes up on it because under the Health Act, which was established in 2017, it established an emergency kit, fund that will be able to cater for every Kenyan who need emergencies. So it is only in this social health insurance that we are now establishing that fund. And it is a responsibility of government to appropriate that money and put it there. So I say it is good, but when you find that already the process is being castigated by virtue of the inconveniences, Kenyan and the healthcare workers, we have lost trust. And again, we have said, we as the healthcare workers who are working in that sector, who are more prone to more diseases, we need a better terms. Because in any case, we used to earn a medical cover, it's called medical allowance. Then we forfeited that money, which this money was about 5,000, and it was taken now to buy us a comprehensive medical cover that at any time I should not go to fundraise. Now, where we have been subjected is that we will still go back to that problem, and we are saying provide a cure to that.
Yes, and Daktari, you are very well aware of some of the challenges that we used to have with NHIF. Like you go to the hospital, you find like NHIF is only covering bed expenses and just a few nitty-gritties here and there. And for me, what I really envision in our health sector, and that is why I'm a proponent of SHIF to be fully implemented as soon as possible. We don't have to take any more time. Whatever challenges that or teething problems that we have, they're things that we can solve as we move on. Because I want to see a scenario where a patient who is diagnosed of end-stage renal disease goes to the health facility and gets full dialysis and only has to use their SHIF card. So for me, despite the many challenges that we are alluding to in terms of transition, I feel like there's no correct time to implement this thing, and it needs to be implemented as soon as possible.
Okay, so with that, Katibu,
yes,
what do you think is the recourse we should take?
The recourse we should take first is the uniform of the president. One thing I know that having worked with the president during the campaign time, he has the goodwill. And actually, the health sector has a very goodwill. Only if they can tell the president that this is how we need it, and he is a candid man, he will address it. Unfortunately, I feel that there is a gaps in terms of those who are informing the president in terms of the right steps and what is it that we need to do. And we must call a spoon, not a big spoon, or a spade, not a big spade, a big spoon. What does that mean? We have a problem with the county. We as the healthcare workers, we have petitioned the president to establish a committee from his office so that then we can do a health audit. Since we went to devolution, we have done a lot of development. We accept, but which development? Facility, because then governors and the MCS and some of the MPs, they think development in the health sector is building facilities. In Nairobi, we have 22 facilities which are not functional. Why? There's no staff. So these are empty shells. They can't offer services without workers. In any case, a majority, like the clinical officers and the other public health officers, they are trained to work in an open space. Hata chini ya mti tutapeana services. So we don't need those complex building. In any case, in a country where our desire and our big push is to realize, or rather to do a policy shift where we invest in primary healthcare, then we must ensure that the engine to propel service delivery, to ensure that we realize the UHC are the human resource. And this human resource, they need respect, they need to be they need to be well treated, and they need to be listened to. You don't treat them like a second citizen, and then you expect output out of that. I think any employer is advised actually to put more energy into the employees so that then the output is there. The president need to be a hallmark. I mean, he need to be an umpire, the umbrella, in a manner that when there is a problem, he doesn't go and speak before he listens to both parties. Let him call the unions. What are your issues? What is the issue? He is the president for everyone. He's not a president for the cabinet alone. He's a president for everyone. Call everyone. Call all the stakeholders in the sector and say, you Kenyan who is not employed, what is your issue about this health issue? You the employees, what is your issue? You the leaders of these employees, what is your issue? You now the people are put there to lead 1, 2, 3. What is your issue? We can't continue coming up with policies that we never implement, keeping them in our offices, gathering dust without any implementation. We have seen this government already have given us 4 acts of parliament in the health sector, and all of them now, because that was last year, and they were being rushed so that they can take effect. Remember, before the president went to launch the UHC issue in Kericho. Have they assisted the system up to date? No. Where is the problem? We need a whole of the country approach audit so that we put chaff and wheat kando, tuseme sasa hii problem yenye imekuwa na Wakenya wamesungumzia ni 1, 2, 3, and the way to address it is actually by ensuring that then if the county must continue to, having the health sector, which we know that how can I call it? The devolution of a health sector has actually contributed to development, but imefikia mahali sasa it cannot grow anymore. So what is that problem? How can we unlock that issue? The president must put a team that is non-partisan, go do the audit like the way he did in the education sector, and then he get a report and then act on that report with at least a proper information. Otherwise, he's being misinformed, because in any case, when you shout or try to mute the healthcare workers, the voice of the health sector, you are killing that health sector. And 5 years is not long. His expectation was actually to ensure that what did not happen with the previous government can happen with this government, can be realized, the UHC. It will still be a mirage after 5 years if he doesn't input the right steps, or rather do the right, take the right action to ensure that it is realized. Invest in the human resource, invest in the human resource, invest in the human resource. Thank you.
Invest in the human resource is what Katibu is telling us this morning as his recourse. Anthony, is the ministry and the CS in particular doing enough to address this issue? Because we have seen the tug of war between the ministry and the unions, the various unions. How can the ministry come in to play the role of referee, for lack of a better term, but also ensure that they find a way forward? Because like I keep repeating, at the center of this, in the middle of this, is innocent Kenyans who are losing lives. When you go to hospitals, especially at the primary health levels,
yes,
the stories are grim. And we cannot continue to lose Kenyans. You can imagine with the floods right now, the communicable diseases that will come with it. And then we have the strike. What do you think is going to happen to our fellow Kenyans?
And I think I should have started by acknowledging the kind of work that our doctors are doing, our clinicians, our nurses, our nutritionists, all of them. They do a brilliant job, and ideally that's why they are identified as essential workers. And we were talking about the 2017 CBA, and we also have to be realistic in everything that we do. The government spokesman has been very categorical that the CBA was signed under duress. Keep in mind that it came into action on 1st of July 2017, which was barely just over a month to the general elections. So even the issues that were addressed, it was like some of the things that were placed in the CBA were more of political promises rather than realistic promises. And what the government is trying to say is we have to be realistic. We have to be realistic in this issue. The government is not denying the doctors everything that they are requesting for, and that's why I initially stated, and that's why they were able to agree on the 18 issues. It's only that one issue that about the interns that is not yet agreed upon. And Dr. Ari, I'd really like to correct you on something small. Part of the 4 bills that were signed, there was the Primary Health Care Act, right? Mm-hmm. And if you look at the current situation that we have in the country right now, just look around and the people that are on the ground, it's the community health volunteers who are the community health, the promoters. You'll see people with light blue bibs around helping out the people. So I'd say that it is very inaccurate to say that it is not in action, because these are the people who are on the ground. Dr. You know that very well.
Yeah, I agree with him, mm-hmm. But these people, it's not that they were not there. Mm-hmm. We had them. We used to call them community
health volunteers. Yes. So it's just that they have ratified
because the House did not push at the ILO mm-hmm. and the WHO to change that name, because in any case we were taking them for granted mm-hmm. despite offering them as services, so that in any case we stop underrating people who are giving a service and appreciate them in terms of payment. So that's why we push it to community health promoters. Mm-hmm. But promoters, when you call them promoters in any case, and I appreciate that they are in place now, at least yes, the number increased a bit, and they tried to put them in the structure. How do we pay them well? What is the minimum wage in the country? It's above.
Why were we calling them volunteers in the first place?
It is because we wanted to have them to offer us services without any pay. Mm-hmm. Because then we call them, they are just frontier, but you still need their services. Collecting data, you still need them.
Yes.
So
are they personnel employed by PSC? Because you're talking about wage bill. Whatever they receive is a stipend. It's not a salary.
This is just semantic. Because in any case, where is this money coming from? Mm-hmm. It's still from the public coffer.
Yeah. Mm-hmm.
So whether we call it wage, mm-hmm. whether we call it stipend, whether it's still public money. Mm-hmm. So you want this person to take the whole day working for you or moving around meeting over 50 family household, and then you give them 2,500, 5,000. This, even the amount to move around is higher than that. Connecting from that place to place, you get tired, you'll eat some banana, use motorbike, you'll do what? Mm-hmm. The cost is higher than even the amount they are being getting. We are only saying, for us to be a country that honor its people, appreciate them. You give a CAS over 780, close to, actually when you put amount that was put together is above $1 million. A single CAS, $1 million, who is coming to sit there, we have been doing without them for over a year. But you want to bring them by force, by fire, into office, paying them that huge money, which in any case you spread across the money that they're going to get, is enough actually to pay, to add money to these community healthcare workers who are taking care of our people at home. When now you hear that clinical officers are pushing, that they were promised in 2021, they are pushing for implementation of an enhanced, negotiated implementation 2021 up to date, because then issues have changed. you ought actually to have reviewed up. But we are only saying implement first, then we negotiate. This was 2021, it was seen worthy. We are doing 2024, but still you feel it's so difficult. Actually, a total of $1,500,000 that is required to implement whichever we are pushing for. The government is still hell-bent not to implement that, but very keen to bring people who we can do without.
Why is the government muddling unions?
Let me just clarify something small.
As you're clarifying, I would also want to hear, even as Kenyans, we're interested to know. Katibu is seated here as a representative of the clinical officers. We saw also KMPDU and their SecGen and what happened. You know, why is it that we cannot listen? Because sometimes it is a right under the Constitution, a right to picket, you know, and you have given notice, you have given all these things, you have followed procedure.
Yes.
Why is it that even in those instances?
We are listening. The government is listening, or let me say so, because like I said before, doctors and health workers are essential workers, and that is why I'd also like to ask Katibu the same question. They should also honor what the Labour Court, the directive that the Labour Court gave. We are not refusing or disallowing them to picket or to do their demonstrations. No, but since they are essential workers, it needs to be structured so that essential services are not paralyzed like what we are seeing. KMPDU is telling the government to honor the 2017 CBA agreement. And like I said, as much as you might not want to hear it again, the government was able to sit down with the doctors and agree upon the 18 issues. So it is not that we are not listening. And I'd also like to call upon the doctors to also honor what the Labour Court, the directive that the Labour Court agreed upon. And something else I also want to clarify about the community health volunteers, because like I said, it's something that I really hold dear. Initially, they used to be called community health workers, right? If you understand the community health strategy well.
Community health volunteers.
They used to be called community health workers, but it was changed to community health volunteers. Because if you call someone a worker, that is someone who receives a wage or a salary. And initially they were volunteers. They never used to receive anything from the government. They used to rely on maybe outreach services. They're given maybe transport here and there, and maybe the support that partners used to give them on ground, the NGOs and the CBOs and the foundations that they used to work with in some of these outreaches. I think I'm right, Dr. Ari, right?
You're right, actually.
And now
some of those
the government
used to pay them better than now what we are
the government came in to ratify that, because community health promoters, as they are called right now, they do not work 8 to 5. They are allocated a certain number of households which they're supposed to follow up through the month. So they may take like 2 or 3 days to go through their households and also respond to emergencies at household level. And that is why the government recognized all these efforts that they are doing. And they decided to partner with the county governments, to partner with the national governments, to give them a small stipend in a way just to appreciate them and everything that they do. And these community health promoters, they're not just anchored to health alone. They also serve as the watchdogs of the community. So when we say that we are mistreating them, actually I'd say the government is very intentional about bringing them on board and appreciating them for everything that they have been doing over time.
So let me finalize that as healthcare workers, we have the goodwill. What we are pushing for is actually improvement in the service delivery, enhancement of service delivery, ensuring that no Kenyan is losing life by virtue of appearing in a public health facility and there is no one to see them. We want the government to be responsible and appropriate enough money to run the health sector. If there is issues that is lingering around restructuring the healthcare system, we need to do it. Because in any case, we can't continue affording these recurring issues. Same issue that was there 2012, 2017, 2024, they are the same issues. We need to see government officers who are proactive. You don't have to continue postponing issues, this mentality of wait and see with government officers. It must stop. Why are they in office? They are supposed to implement government policies. When you hear the people like Moses Kuria declaring that we'll put everyone on contract, and yet they swear to protect and uphold the constitution and the laws under the country. So you still have laws that have provided your existence in office, have provided for any other Kenyan a right to exist in that position they are. You continue actually doing roadside declaration without a proper procedure. And then we normally say, where I come from, that when you see any dog parking, there is the owner. So that's why we are saying the owner need to correct this. Because in any case, we need government officers who are implementing policies for the benefit of Kenyans. Do not wait and see and come only pronounce political pronunciation so that people continue talking and losing the traction or rather focus in terms of the service they want from you. President Ruto must take responsibility, must correct this. We are his big supporters. But again, we should not behave like we can't tell him that something is wrong. We are brave enough actually to tell him that health will have been the biggest winner for him if actually he put his hand right and do the right thing. In any sector, leave alone whichever is happening in the health sector, and the other sector like agriculture. The health sector, if you press the right button in terms of the human resource, in terms of cancer issues, in terms of the NHF, you have it right. Thank you.
Okay, so that concludes our discussion this morning. That was the state of the healthcare system in this country. And hopefully as Kenyans, you've been able to hear from the representatives that are here today, both from government and also from the people on the ground, as we like to call them. I have been your host today, Chepkoech. Yes, what to ground.
Yes.
I have been your host. So if you missed the conversation, don't worry. It will be uploaded to our YouTube channel. That is New Day TV. It is on our Facebook, New Day TV. Also, like, share, subscribe, comment. Let's have a conversation and advance this conversation. Maybe in talking and contributing, we will find a way forward. We will find a solution that is lasting for this country. Thank you for joining us. Thank you for being with us this morning. We really appreciate. See you tomorrow, same place, same time. Tackle TV, Siasa Wednesday.